Hi everyone, and welcome to this third session of the first module, the BSNR Online Education Programme. So this is soft tissue neck trauma. My name is Tom Campion, I'm a consultant neuroradiologist at Barts Health, and we're going to talk through a number of different elements of soft tissue neck trauma today. The main point that I want to make really is that sometimes as neuroradiologists we can see the cervical spine as this, and this does a disservice to the interesting and complex anatomy of the rest of the neck, which is equally important in trauma. And so we really need to have an approach to looking at the soft tissues of the neck and understand what the clinically important injuries could be. So what I'd like to do today is take you through a few cases which will allow you to hopefully apply an appropriate imaging protocol to penetrating and blunt neck trauma, identify clinically important injuries outside of the vertebrae and spinal cord, and understand their clinical implications and suggest appropriate further investigations. So when we're talking about neck trauma, we can divide it into penetrating and blunt trauma. And the key aspects I think in penetrating trauma to think about are the trajectory of the penetrating object and what that penetrating object is, as the nature of the object can have a significant impact on what the injuries you might expect will be. In terms of blunt trauma, you need to think about the mechanism and the level of energy that's involved. And you also need to remember that the forces that are applied are not just at the point of impact. You may see more remote injuries. I have this idea of untrustworthy gas and trustworthy gas. And essentially, when we think about gas as showing that there's a defect or a leak in a viscous, we have to be a bit careful in the setting of penetrating trauma because the missile or the penetrating object can introduce gas. So we have to work out whether it's disproportionate to what we would expect for that, which can sometimes be a bit tricky. Whereas in blunt trauma, it usually tells us there's something significant going on if there is trustworthy gas in the absence of a penetrating injury. So obviously these are the kind of things that we're thinking about when we're looking at soft tissues. And today we're primarily going to talk about arteries and a bit about the aerodigestive tract. But obviously you need to think about venous injury, injury to the nerves, which we often see as secondary deficits. And the larynx we're going to spend a bit of time on, but we also need to think about the pharynx, the esophagus and the trachea, salivary glands and the thyroid gland. So to start with penetrating trauma. We have a zonal division of the neck in trauma, and this is not the same as the nodal system that head and neck radiologists will be familiar with. So zone 1 is considered to extend from the sternal notch to the cricoid cartilage, zone 2 from the cricoid cartilage to the angle of the mandible, and zone 3 from the angle of the mandible to the skull base. Now these are historic, but they are very useful for a common language. And the reason they were originally devised is because zone 2 is the surgically accessible area. So it's useful to know about zone 1 and zone 3 injuries because they're more difficult to access surgically. They may require either cardiothoracic or neurosurgical colleagues, and they may be less clinically apparent. Obviously, injuries often transgress these boundaries, and the point of penetration may be in a different zone to the significant injury, depending on the trajectory of penetration. In terms of our imaging approach, the key imaging modality here is CT angiography, and unless there's urgent surgical exploration, that can be for a number of factors as listed here. Most of these patients should go straight to CTA. You can consider doing an on-contrast CT first, particularly if you're worried about intracranial injury or infarcts, but CTA is the imaging examination of choice. When we're thinking about the trajectory, you've got to look for an entry wound. You've got to make sure that if you can see any injuries, you can link them along a specific tract. Gas and hematoma can be very helpful in delineating a tract, although obviously they can diffuse away from the site of the specific trajectory. And the key thing here is to make liberal use of multiplanar reformats. So here is one example of someone who's been shot in the chest, And you can see that we have a bullet which is in the soft tissues of their back, but you can see fragments of the bullet going along a tract which I've reconstructed in some very odd oblique planes. And this takes us through a fracture of their rib and then through the lung to the site of the entry wound. So we're going to start with case 1, which is a 20-year-old male who was found down after a fight. And this is his CTA. So you can see immediately that there's quite extensive intracranial gas. And if I take you down to the oropharynx, you can see there's a little mucosal defect here. And if we switch to bone windows, there's a little fracture of the anterior arch of C1. And we follow that trajectory through from the pharynx, through the anterior arch of C1, and through the atlanto-occipital membrane. And there's obviously a CSF leak here. This patient's at risk of meningitis. They're also at risk of forming a retropharyngeal abscess because of the defect here. So we've established it's very important to follow a trajectory through so you can see all of the key points along the way where there might be an injury. The penetrating object itself, obviously we need to know if it's still there. It can be a focus for infection or it can embolize, whether it's high velocity or low velocity, and that's usually what we're talking about in that situation, is whether it's a stab wound or a bullet, and if it's a bullet, whether it's from a handgun or rifle or from a shotgun or an air rifle. All of these projectiles might embolize, and so it's really important for us to be aware of that and of their relationship to any vessels. And we also have to think about secondary penetrating objects. So for example, if you've caused a fracture, whether you have a secondary injury from bone fragments. So this is an example of penetrating a foreign body. And if I take you to a still image here, you can see that there's radiolucency, a very clearly defined area in the retropharyngeal region. And you can see the left internal carotid here and the right internal carotid artery is not visible. So they've had a occlusive dissection injury, and this was actually a wooden pole. And this is an example of someone who's been shot with a shotgun. You can see the pellets here are relatively dispersed. And when the pellets are more dispersed, it suggests that the shooter is slightly further away, and the degree of injury locally is likely to be less if the person is further away when they shoot. So it's still very important that we get cross-sectional imaging. These happen to all be fairly superficial, but we still need to delineate their relationship to any vessels. And clearly there are still structures like the eye which might be at risk even from very relatively low energy projectiles. Okay, so we're going to move on to our second case now, which is a 30-year-old man who was shot in his left shoulder. And the key here is this is another trajectory question with a secondary implication of a much higher energy projectile. So we can see an entry wound up here. You can see the multiple fragments of bullet. You can see that it's caused a complex fracture of this upper thoracic vertebra. But we don't want to stop there because we can't see a bullet fragment anywhere in the anterior cervical soft tissues, and we can see what is probably going to be an exit wound. So we've got quite significant disruption around the anterior cervical soft tissues. You can see there's a thyroid injury here, and there's probably a mediastinal hematoma. And we also have to infer from the retropharyngeal gas and potentially prevertebral gas that there may be esophageal or pharyngeal injury as well. So this patient will need a water-soluble contrast swallow at some point. So when we're talking about the penetrating object itself, we have to think that if it's a knife, you may see a cleaner trajectory, which may mean that the wound itself is more difficult to see, and you have to remember that you may not see the full extent of it, and you have to extrapolate it going forwards. because you may not see gas or hematoma along the entire extent of the wound. You can have a blunt component to some penetrating injury, for example, if you use broken glass, where you have a laceration tearing injury as well as the direct penetration. And obviously, as we've said, it can introduce gas. These tend to be lower force injuries with small fracture fragments and less comminution, but obviously it depends on the size and intention of the person who's doing the stabbing. Bullets are a whole different kettle of fish. So obviously single bullets, you have to think they're likely to be very high velocity. The degree of damage they're going to do will depend on the bullet itself and its ability to deform or fragment. If it can deform or fragment, as some hunting ammunition can, then it's likely to deposit more energy in the soft tissues, and that causes more localized destruction. And you get this secondary cavitation effect, which can mean that you get much more significant soft tissue injury than you might expect for something passing through. Shotgun pellets, again, we need to think about this dispersion distance relationship and how deep the pellets are going as a result, but also to think about embolization and their relationship to vessels. So wood can be radiolucent, so that's something to bear in mind. And we also have to think about other potential penetrating objects like bone fragments. Okay, so we're going to look at something slightly different now. So this is a 30-year-old man who was stabbed in the back of his neck. And let's switch this to soft tissue windows. You can see there's quite a lot of gas in the posterior cervical soft tissues. We surmise that there's probably an entry wound around here and an upward trajectory. And then if we go back to the vascular view, you can see there's a focal narrowing of the distal V3 segment of the right vertebral artery, and there's a large outpouching of contrast which appears contained in keeping with a pseudoaneurysm, but there's also some earlier pacification of the surrounding venous plexus, which raises concern for an arteriovenous fistula. So this went to angiography, and you can see the where you've got the vertebral artery opacified, you've got a pseudoaneurysm and early filling of the veins, and following coil embolization, the fistula has been closed and the aneurysm has been excluded. So we're going to talk a bit about vascular trauma. So in penetrating vascular trauma, we see arterial injury in up to 25% of penetrating cases in some series, and carotids are more exposed and bigger, and so they're more at risk than the vertebral arteries. There may be this mixture of blunt and penetrating mechanism, so you can get into more adventitial involvement, and we think there might be venous injury in up to 20% of these cases as well, but they're often missed on examination. So if you do have some venous contamination in your scan, do remember to look at the veins, because you can pick up venous injury. And it's also important to remember the potential for venous sinus thrombosis propagating from the jugular vein into the head. In terms of blunt vascular trauma, it's very difficult for us to work out exactly how often this occurs, as we only find it if we specifically look for it. We think of these as occurring with high energy mechanisms, but we know that there can be very trivial trauma, such as head turning or some kind of chiropractic manipulations. So you've got to be a bit careful about where you think the risk is. These are typically intimal injuries associated with this kind of shearing force, but there may be secondary penetration from things like bone fragments. And we do have a grading system for this, as with everything else, which can give us a few things to think about. So this is, I think, a slightly controversial area as to when to CTA in the setting of blunt cerebrovascular injury, or in the setting of blunt craniocervical trauma, I should say. This is a very good paper in radiographics, which really comprehensively covers all of the different systems that have been devised. So I think the best known is the modified Denver criteria, which will give you a very kind of broad range of things that should lead you to do a CTA. But there are other recommendations that have been made as well. Obviously, if you do a polytrauma protocol, which includes a CTA of the neck, some of this is slightly academic, but many places will do a non-contrast CT head and C-spine and won't necessarily include the neck in the post-contrast imaging. And you can see there's an extensive list of potential risk factors. So it depends where you want to set your sensitivity. And I think there is a significant variability in protocols between different centres, and that I suspect many more CTAs are being done in the United States that are done in the United Kingdom. So one rule of thumb that people have is the involvement of a foramen through which an artery is passing, but we've got to remember to go beyond that and think about the mechanism and the level of energy that's been imparted. And also we may get clues from the non-contrast imaging, for example, in Barts, or this is an example of someone who had asymmetry at their skull base on non-contrast CT, and you can see an expanded left internal carotid artery with hyperdensity within it, and that corresponds to intramural thrombus and the left internal carotid artery dissection. So these are the types of vascular injury that we're thinking about. So this is an example of a dissection, which may just present itself as luminal irregularity and narrowing, or as here you may see a raised intimal flap and potentially some luminal thrombus on the flap. Intramural hematoma is more commonly associated with injury to the adventitia and bleeding into the vessel wall, which could be between adventitia and media, and this can also cause luminal narrowing and potentially occlusion of the vessel. Pseudoaneurysm is an outpouching into which blood flows, which is not contained by 3 vessel layers. It may be contained by no vessel layers and just the surrounding tissues. So this is more likely to require some kind of intervention. We've already seen an example of an arteriovenous fistula, which shows this early venous opacification, and this may not necessarily be apparent at the time of injury. Clearly, as with anywhere else in the body, there's active bleeding is seen as uncontained contrast extravasation, and in the setting of occlusional transection, in the carotids we quite often see a kind of tapering, whereas in the vertebral arteries you might see a straight cut-off. And this is the grading system for blunt cerebrovascular injury. So we can see that with increasing stenosis, there's an increase in grading here. So the very, very subtle dissection injuries with minimal stenosis. So there's just a very, very slight irregularity in stenosis here in the right internal carotid artery. You may see some wall irregularity. You may see a small amount of intramural hematoma, and this would be classed as grade 1. Grade 2 is when there's more than 25% stenosis, or if you have a raised intimal flap or intraluminal thrombus. And then grade 3 is when we start seeing pseudoaneurysms. Grade 4 is an occlusion of a vessel, and grade 5 is either a transection or the presence of an arteriovenous fistula. So again, these are increasing in severity, so even if you don't necessarily use this grading system, it's useful to know what the levels of severity are, and this can help us to work out what appropriate treatment is likely to be. So we're just going to take a look at another case now. This is a 40-year-old man who presented following a chiropractor appointment. And if we look through this case, we can see that there's narrowing of the right internal carotid artery here. There's the impression that there's some surrounding intramural thrombus because this vessel still looks expanded when you compare it to the other side, but it's not opacified with contrast. So this is a right internal carotid artery dissection with intramural hematoma. So what would you do? Well, if there's any doubt about the diagnosis, you can consider a follow-up CTA with or without giving antiplatelets in the meantime. Sometimes in the setting of polytrauma, it can be very difficult on the initial images, which can be degraded because of the other injuries or surrounding paraphernalia. So sometimes things are clarified on follow-up CTA. If it's going to make a significant difference to management, you can think about doing a catheter angiogram, particularly if there's any concerns about potential pseudoaneurysms. Or you can do an MRI, which can more clearly delineate some of these injuries. So for example, in that case, there's the intramural hematoma is seen nicely on the T2, the T1 fat sat, and diffusion images. And the T1 fat sat is really the sequence that you have to acquire in order to get maximum sensitivity for dissection in intramural hematoma type injuries. And then the treatment obviously depends on the severity, and it'll depend on other factors to do with their other injuries as well. But grade 1 and grade 2 injuries we can often treat conservatively and give antiplatelets and or anticoagulation, whereas grade 3 and above are much more likely to need endovascular or surgical treatment, though this will vary according to the specific cases. So our next case is something slightly different, of a 60-year-old male who had a fall and neck pain. We're moving on to a slightly different area now. So I'm going to take you down to his larynx. And on this you can see that I'm going to point out the hyoid bone to you, and where we should have our ariepiglottic folds at the base of the epiglottis. We've got very, very swollen left ariepiglottic fold, and in fact the left supraglottis, there's a lot of it asymmetrical with expansile soft tissue with some areas of hyperdensity extending into the left side of the hypopharynx. So we think there's supraglottic edema and probably hematoma. As we come further down, we come to the level of true chords. These are not perfectly angled, which I apologise for. You can see there's medialization of the left true chord. And as we come a bit further down, we look at our cricoid, and there's a fracture here as well. You can see there's some paralaryngeal hematoma as well. And the location of this is important because we know that the recurrent laryngeal nerve will enter the larynx at the level of the cricothyroid joint. So it's important for us to comment on injury here, and particularly in the setting of cricothyroid dislocation, which we don't have here. There's a significant risk of recurrent laryngeal nerve injury, which we suspect here due to the medialization of the left vocal cord. So we're talking about laryngeal trauma, and this is on flexible nasendoscopy. They saw a swollen edematous epiglottis and arytenoids, and supraglottic hematoma, and an immobile left cord. So this was managed expectantly with tracheostomy, and subsequently they had a full recovery, although they had mild dysphonia initially due to recurrent laryngeal nerve neuropraxia, which then resolved. So when we're thinking about laryngeal trauma, for us who are focused on the bone in C-spines, we really need to think specifically about the soft tissues. Look at the epiglottis, the ariepiglottic folds, look at the supraglottis and the true chords, and for any obvious mucosal laceration. And we really need to remember that if it is edematous, that may worsen before it gets better. And it's important that someone is aware and, if possible, has a look at it. And they need to be given steroids in the interim. The laryngeal osteocartilaginous framework is quite difficult to assess if there's variable ossification of the thyroid lamina, but really look for things like buckling and discontinuity of those thyroid lamina, as well as fractures in the ossified parts of the framework. Disruption of the thyrohyoid membrane can be difficult to identify on imaging, but we can infer it from paralaryngeal hematoma and displacement of the hyoid-thyroid cartilage relationship. And obviously there are secondary effects, so we really need to think about what degree of airway compromise there is, the degree of surgical emphysema which can lead to airway compromise. And as we've sort of mentioned already, consider any risk to the recurrent or superior laryngeal nerves. And with a recurrent laryngeal nerve, we're really interested in that inferior corner of the thyroid cartilage or cricothyroid dislocation. And obviously we're looking for any signs of vocal cord palsy as well. So our next laryngeal case is a penetrating one to a 50-year-old man who was assaulted, stabbed in his neck. So I'm going to start with this on bone windows, and you can see there's a great deal of surgical emphysema, some of which is endolaryngeal. Their hyoid bone is intact and their airway is protected with an endotracheal tube. But they do have fractures, so they've got a fracture of the left side of their ossified thyroid cartilage and the right inferior cornu. And actually, if we go back to the soft tissue windows, you can see this fracture. There's an extension to the mucosa just below the level of the glottis. So we've got a subglottic mucosal laceration, which may account for some of the endolaryngeal gas as well. And that's what they found. So they had a surgical repair of the laceration and of the thyroid lamina, but they had some scar tissue which required further treatment. The next case is a 40-year-old man who had a self-inflicted stab wound. And this is quite a difficult angulation of the patient in the scanner, but even allowing for that, we can tell that this is the hyoid bone here, and this is the larynx here. And there's a very odd relationship between the two. We've got quite a lot of surgical emphysema, but we've had a penetrating injury, so we don't know how trustworthy that gas is. And we've got big paralaryngeal hematoma, and particularly here, we've lost the normal fat planes around the larynx on the right. So with that disruption of the normal relationship between the hyoid and the thyroid cartilage and this paralaryngeal hematoma, we really have to think, even though there isn't an obvious osteocartilaginous fracture, that there may be disruption of that right thyrohyoid membrane. And sometimes it can help to do recons here, and you can see that this relationship doesn't look normal. We've got a low-lying hyoid bone with an abnormal relationship to the thyroid cartilage, significant paralaryngeal hematoma, endolaryngeal gas, and we can infer that there may be thyrohyoid membrane rupture, and this was actually confirmed and repaired surgically. Okay, and moving on to something slightly different again, we've got a 20-year-old male who had a left neck stab wound. Okay, so we can see that the entry point of this stab wound is likely to be on the left face here, and we've got some surgical emphysema tracking through. Now, some of this may be introduced by the knife, but there's quite a lot of retropharyngeal gas here, which is probably disproportionate, and this passes extremely closely to the left lateral pharyngeal wall, which is very, very thin in this location, and in combination with that retropharyngeal gas, there's probably enough, well, there is definitely enough here for us to suggest that there might be a pharyngeal injury. So in this setting, you would think about advising a water-soluble contrast swallow, but this patient actually went to theatre where they confirmed a left lateral pharyngeal defect, which was then repaired. So in terms of other penetrating injuries, trajectory really is key, and in that case, obviously that made the diagnosis for us, because pharyngeal and esophageal injuries can be very difficult to identify unless there's an obvious mucosal irregularity or deficit, which is not that common. So if that trajectory runs close to the pharynx, we need to do a water-soluble contrast swallow. If we miss it, you can get very severe complications, for example, retropharyngeal abscess and extending to mediastinitis. So it's really worth us suggesting the swallow if we think there's any chance there could be a pharyngeal injury. Similarly with tracheal injuries, it's very difficult to identify them on cross-sectional imaging, but you will see disproportionate surgical emphysema in a majority of those cases, although significantly not all of them. And that should really suggest to you that they need to go looking for a tracheal injury if it's not clinically obvious. In terms of salivary gland penetrating trauma, the major risk is with a parotid gland and the facial nerve running through it. So if you have a significant parotid injury, you really need to interrogate facial nerve function, and that may need exploration. There's also the possibility of injury to the salivary ducts, and you can get a sialocele formation or persistent duct problems, so you can consider investigating that with a sialogram, although that's clearly less urgent. Thyroid gland injuries are usually treated conservatively, so it's important to mention them, and in rare cases they will require operation, but generally it can be treated conservatively. So this is an example of what I mean by disproportionate surgical emphysema. This is someone who had multiple left-sided neck stab wounds, and you can see there's very, very extensive surgical emphysema throughout the neck and the chest. And I think it's very, very difficult on here to identify the site of injury, but operatively it was confirmed to be upper tracheal penetrating injury. Okay, so our next case, case 9, is another stabbing, a 40-year-old male who was stabbed in the neck. And this is mainly to demonstrate you've got a penetrating stab wound from the left side of the face, expansion of the masseter and expansion of the parotid gland. There's an active extravasation from external carotid artery branch and hematoma around the deep lobe of the parotid, and some hematoma and surgical emphysema tracking down along the neck. You've got some deep hematoma which is mildly narrowing the upper airway. But the key point here is to think about what the potential risks are in terms of this injury. And this patient was found to have a facial nerve palsy. They actually had an intact facial nerve at surgery, and they had a neuropraxia which resolved after a few months. But it's important to flag this up as a potential injury because it may get lost in all of the vascular and hematoma injuries elsewhere. And then if we go to case 10 as our next case, which is a 60-year-old female who was in a road traffic accident. You can have a look at the bony injuries separately, but essentially they had skull-base fractures, and so a CTA was performed. This shows some abnormal filling of veins around the right vertebral artery, raising concern for vertebrate venous fistula, although this didn't require intervention. But they also had asymmetrical and abnormal filling of the right cavernous sinus with arterial contrast. You can see the internal carotid artery quite nice and normally on the left-hand side, and the cavernous sinus around it, whereas on this side there's expansion, which is highly suggestive of a fistula. And if we go further up, we can see the right superior ophthalmic vein is asymmetrically enlarged compared to the left, and these together are extremely suggestive of a caroticocavernous fistula, which this person had. So this was their subsequent angiogram, and you can see the fistula and the early filling of the venous structures, which was then closed with coiling. And this is our final case. So this is a 50-year-old man, very sad case, who hung themselves. And I'm going to show you their scan. So we ignore the facial appearances, which weren't actually related to the hanging. They've clearly got extensive surgical emphysema in the neck. And you can see there's a lot of hematoma around the region of the thyroid membrane, and all of that surgical emphysema, despite the fact that there's no obvious laryngeal fracture. You'd be concerned about thyroid membrane rupture, but the observant of you will notice that there are also complex dissections within both common and extending into the left internal and external carotid arteries. So these are significant dissection injuries, and this patient developed endoluminal thrombus and had intracranial infarct, unfortunately. So hanging, there are some hangovers from judicial hanging, which was having a much higher degree of force, and that was more likely to lead to cervical spine fractures, hence the hangman fracture. But it's actually relatively uncommon to see those fractures in suicidal hanging. And actually the injuries that we're much more likely to see are vascular injuries, particularly your carotids, but also vertebral arteries, and hyoid and laryngeal injuries. And these are things that we should really be scrutinizing on the CTAs that we should be doing. So, in summary, what I hope I've convinced you is that there are good reasons to look outside the vertebrae when we're looking at cervical trauma, whether it's penetrating, in which case we should really think about the trajectory and consider the penetrating object and what additional information we can get about the potential injuries from that. or whether it's blunt injury, in which case we should think about the energy of the mechanism and any potential for remote injury away from the site of impact. And I've included the known unknowns. These are things where we know that there is a risk, or we think that there's findings suggestive, but we need a different study to confirm. So CTA, obviously, in blunt cerebrovascular injury, water-soluble contrast swallow, which we should be recommending if we suspect there's pharyngeal or esophageal injury. And obviously direct inspection, which is really important, particularly in polytrauma cases, where we may be the first people to suspect laryngeal injury and send people looking for it. So there are a number of good articles here which I would really recommend you looking at. I think if you're interested in penetrating trauma, there's an excellent article in Insights into Imaging by Curtis Sophia. And in the laryngeal trauma section, Nell Rebecca has written a very readable review, which goes into a lot of detail. And I think the blunt cerebrovascular injury, the argument around whether it's CTA or not, all the information I think you need is in this radiographics paper from 2018. So these are all very much worth having a read of.